So good afternoon, everyone, and thank you for joining us for our seventh workshop for this rulemaking. My name is Amelia Boyd, and I am the program manager for the WMC. I'll be facilitating today's session. This workshop is being recorded, and we'll post the recording to our YouTube channel soon. The documents we'll be discussing are available on our website at wmc.wa.gov. In this slide deck, the globe and the YouTube icons are clickable and will take you directly to those resources. For attendees, if you'd like to ask a question or make a comment, please use the raise hand function. We'll call on you as soon as we can. When offering comments, please avoid reading aloud any written remarks that are already included in the materials. These workshops are intended to be collaborative with a back and forth exchange of ideas about the proposed language. Before we get started, I'll take roll call of our panelists and staff. When I call your name, please introduce yourself. So Marlon?
Afternoon. My name is Marlon Basco. I'm a policy analyst with the Department of Health, and I support the commission in rulemaking.
Thank you. Dr. Chang?
Hi, Poshin Chang. I'm a family physician. I'm one of the commissioners.
Kyle?
Good afternoon, everybody. I'm Kyle Kiernan. I'm the executive director for the commission.
Thank you. And Ed?
Hi, good afternoon, everyone. My name is Ed Lopez, PA, and the vice chair of the commission.
And Heather?
Yeah, Heather Carter, Assistant Attorney General here as legal advisor to the commission.
Thank you. Dr. Domino, please introduce yourself and then begin the script.
Hi, I'm Kara Domino. I'm one of the commissioners, and I'll be the presiding officer for this rules workshop. Today is Monday, April 27th, and it is now, looks like 1:04 p.m. This meeting is being held via Teams webinar. The rule being discussed today is regarding opioid prescribing general provisions in both Chapter 246-918 WAC for physician assistants and Chapter 246-919 WAC for physicians. The CR 101 or pre-proposal statement of inquiry was filed as WSR number 25-10-039 on April 30th, 2025. Ms. Boyd, please present our proposed timeline for rule development.
Here's our proposed timeline for this rulemaking, which may be adjusted as workshops are held. If there are any questions about this timeline, please use the raise hand function and I will call on you. Does not look like we have any hands raised.
Okay, well, as you can see from this, that Ms. Boyd has out, we have future workshops scheduled for this rulemaking. So we will now. The next item on the agenda is the draft language beginning with WAC 246-919-865. At around 2:50, we'll pause our discussion and discuss next steps.
Okay, so for this section, what we did was we moved some of the information that was at the end of the section to the beginning. And so this is not new, even though it looks new, it is not new. And let me do one thing real quick. I know it's hard for some people to see when I'm in dark mode, so let me change. On just a second. There we go. That's probably better. So that's all we've done here is move this to the beginning from the end. So that's all what section 1 is. It's what was at the end. And then we've made some additions to 2A. Does anyone have any questions about this addition?
No, it's reasonable.
Okay. And then again, we moved what was into to 1. So this is not a strikeout. It's just that we moved it. And then we just updated these references to section 2 instead of 1 because we moved 2 to 1. And then we just struck this word and replaced it with regulatory. Does anyone have any issues with any of that or need to make any additions to this section that you're aware of?
So this is Heather. So the provision that you just changed disciplinary to regulatory, 18130.040 is about disciplinary authority. So I'm not sure why you would change that. I think it probably needs to stay the same.
Okay. And that's fine with me. I don't know if anybody else has any heartburn about that one.
I guess I have a question as to what was the origin of the change? What prompted the change?
That I don't know because Micah made this change and he's not here yet, so I'm not sure.
Okay. All right.
Actually, just joined.
Oh,
what are we
there
looking
he
at?
is. We're looking at, can you see our screen? I'm not sure where you're at, so.
Yeah. Let's
Okay.
see.
So this is 865.6. So Heather was saying that 040 is referencing disciplinary authority. So she just said that we should probably just keep it the same.
Right, but the statutory authority listed is under 1871. It appears to be 017 and 810. So that was the meaning for the change. This isn't exclusively disciplinary. The other piece is that just the broader term regulatory encompasses all of the licensing authority and disciplining authority stuff that we do.
So Heather, do you have any more input on that?
Yeah, I'll look at it. I mean, it's not a big deal. I just it didn't flow when you're citing authority that's disciplinary authority and you say regulatory. That's fine. I'll look at it again.
Okay. So we'll revisit this one. Okay. I'll just make a little note. Okay, so do you have any other questions or any additions you want to this section? And again, this section is patient notification, secure storage, and disposal. So we're all okay with that one?
The green changes are from where? Is that something
So this part
just
right
a
here
different
is just,
section?
yeah, we just took from section 2 and put it in section 1
Okay,
so that it's
thanks.
up front. Yeah. So this isn't truly a change, it's just been moved. Okay. So if there's no other questions or other things we need to add, I think we can move to the next section, yeah?
There was a little blue thing. Was that not, it wasn't green? That, yeah.
Yeah, that was just
Oh,
something
that one
that,
we already looked
yeah.
at. Yeah.
Yeah, we already looked at that one. I went back up in the section, sorry. And this is everything that got moved to 1. This might need to be changed. That needs to be changed to 2. Okay. And then we'll revisit this later. Okay. So next we'll look at 870, which is the use of alternative modalities for pain treatment. I'm not sure if we have any changes here. We do. So again, everything that's not underlined is already existing. This is only underlined for grammar. And so this is something that's been added, this sentence. Are you okay with the addition of that sentence about patient function? Okay.
I'm fine with it.
And then we didn't talk about it, but as you know, we did receive a petition, I think year before last, that started this rulemaking effort. And so there's some areas that talk about that. So this is part of the petition. So Maria Higginbotham sent in the petition, and then they provided us with some red line comments. So they went through the whole rule and redlined. And so I've just incorporated their suggestions in here. The full comment is number 111, which is in the materials. So I didn't want to go back and forth between the draft and the material. So I just incorporated it in here, and it's just for you to consider adding it to this section.
I'm fine with it. I just don't know if the prior attempts, life changes, right, over a period of time. They should have good documentation of prior attempts or failures.
Mm-hmm.
But there may be treatments that might work better with change over time. I don't know. It seems to, I don't know if it's necessary, but I don't mind it.
Okay. Go ahead, Rose. You have a comment?
Hi, this is Rose Bigham from WashPip. Jeb's not here, so I'm going to wear his hat for a second and say this is a lot more language we're adding when I think some of our goal has been to simplify this and put less prescriptive guidance in and put guidance back in the hands of the provider. So is there a way we can, like, I love the blue sentence. Can we shorten the red line section to just say providers should consider, all aspects of multimodal care where appropriate? That's it. Just like, I can't imagine they aren't already considering non-opioid therapies, but just tell them to consider every tool in the toolbox for every patient and figure out what's appropriate for that patient and party on. I just hate the idea that we're having to tell providers, like, don't forget there's things that are not opioids out there for treating pain. Of course they know that, right? Do we have to put it in the rules? Just, that's my thoughts.
So what you're saying is shorten it to this one sentence, and is that sentence capture what you said?
Yes, fabulous.
I like that. Shorter's better.
Somebody make a note that Jeb will owe me later, okay?
We'll send him a link to the recording and I'll tell him the timestamp. He needs to go listen. Okay. So do we want to go with this sentence as opposed to this suggested addition?
I'm fine with
Commissioners.
suggested change.
Okay.
Yeah.
Okay, so I'm going to delete this from the there. Okay. And you were good with this new sentence as well. So we are done with 870. Does anyone have any other questions about this section or comments? Hearing none, we're moving along. All right. So 875 is about continuing education requirements. There is a suggested addition again from the Higginbotham red line. So right now our requirements are that they have to complete a one-time continuing education that's only an hour. It has to be at least an hour. Also, reading of these rules meets that requirement, so they can review the rules, and that meets the requirement of having completed this. And this goes on more about like when and all of those things. So the Higginbotham red line is suggesting that we add qualifying education includes but is not limited to appropriate pain management for complex progressive conditions. We can't use and or, so we have to use or and, one or the other. The clinical impact of opioid tapering, principles of palliative care, and the distinction between physical dependence and substance use disorder as defined in 852. The one thing I will say about this is that the bill and everything behind this continuing education requirement does not have requirements on what it should be about, except for it does say regarding best practices. That's all that the law says. So I think that I don't think that we can add this in telling them what it has to be about, because the bill that this is based on only says regarding best practices. But I would need some clarification from Heather whether we can be more descriptive about what it should be about.
So I would be reluctant to add in a bunch of more requirements, if you wanted to sort of put out some options, including but not limited to, and then have some topics. That could be something, but you're right. I mean, you can clarify what best practices means, but I think, you've been reluctant in the past to sort of really define, be very prescriptive on what the CE needs to be in general, not just pain management, but in all sorts of CE, so that the person can tailor it to their practice. So I don't know if you want to be too prescriptive.
Thank you, Heather. Maria, you have a comment?
Yes, I just wanted to tell everybody thank you again for what you're doing here, but also just to say that it's been almost 2 years since we did this petition, and a lot has changed since then and now. And so I realize that some of these may come up and we might be looking at them and going, oh boy, this was just way too much. And I do understand that, and I appreciate it. And I just wanted to acknowledge that.
Thank you. So we can do, as Heather suggested, we can change this to say that best practices includes, but is not limited to, appropriate pain management for complex or progressive conditions, clinical impact. We can change it to that, and keep this in here. And then also include, I think it, well, is it not in here? Hold on. There used to be a statement, I thought, that that just reading of the rules, I mean, that's not in here, but it does count. We've always considered it as counting towards this 1 hour requirement if they review the rules. So we could change this to say all of this because it's not limited to, right? And then include the reviewing of these rules also counts. If you want to go that route, or you can leave this out altogether and just keep it how it is now. Go ahead, Rose.
I don't think, and maybe I'm wrong here, and I'll defer to the clinicians in the room, that every doctor needs to extensively study on complex and progressive health conditions, because pain from those types of conditions are going to be managed by a specialist, unlikely to be primary care. So I think it's not entirely reasonable to demand or even suggest that every healthcare provider in the state study up on complex and progressive conditions. I think maybe instead we say, take continuing education appropriate to your practice and patients, right? And again, this is a lot of words that I think we could maybe shorten into a single shorter sentence. Please take continuing education. Please get more of it if you think you need it. Please take what is appropriate for your practice.
So I think I might just rework this section. I mean, depending on the feedback we get from the commissioners. Like you mentioned, Rose, just reword it a little bit. And then I kind of want to include that a review of these rules counts towards the 1 hour.
Can someone read these rules in 1 hour? How many
I
pages?
mean, I'm just saying it counts towards the 1 hour. Read them, probably understand them. And I think we can strike 2 because it is well past. Well, we can at least take this out. I'll reword this too, because we don't care about this date anymore. It's old. Yeah, I'm going to reword this. Okay. So, commissioners, what do you think about adding a little list and including the statement that if they review these rules, that counts towards the 1 hour?
Well, if I'm trying to comment, basically your suggestion is actually more appropriate for the primary care physician. And you're right, not all specialties are going to be, are prescribing opioid. But the thing is that most of clinician, if not all, we all have DA license, pertaining to our specialty field. But the DA license basically includes that all clinician can prescribe opioid medication. And then even though the complex pain management, you say the specialists, supposed to provide those care, but in reality is that majority of pain managements are done by the primary care physician, not by the specialist. Even the one that's a specialty that's approved by the by the state law to provide higher level care, most of the time in reality is that they all got pushed back to the primary care physician to do that part. So the suggestions that I think it's mostly pertinent to the primary care physician, but I can see a lot of pushback from the specialists pushing back and say, this doesn't apply to me, like such as like ophthalmologists will push back and say, I need the DL number to write certain medication only pertain to my field, but now you're pushing me to do additional thing, for that.
Okay, so
I agree with leaving it unspecified, more unspecified. I mean, the problem is, yes, you want to educate the primary care physicians who are taking care of these patients, but I'm not sure you can put it in a rule that affects everybody, all physicians and physician assistants, regardless of practice.
Okay, so what I'll do is I'll rework a little bit. I do want to add in, if it's okay with all of you, that a review of these rules counts towards meeting this 1 hour. And then we can go ahead.
Sorry, dependent on your specialty as well, or your area of, practice.
Right.
Not, yeah, something like that, because I mean, we could add a sentence saying primary care physicians should consider, blah, 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 but I don't know.
So, and another thing is I don't think we can use this qualifying word just because we don't review, like, as long as it's regarding best practices, we don't, like, when we audit CME, we don't go in and say, for this particular one, this requirement, we don't ask them, okay, what was it about or anything like that. It's just as long as it's about best practices. This isn't as descriptive as, say, like the suicide prevention training is. That requirement is descriptive. So I don't know that we can even say anything about qualifying. We could put in here some like suggestions of what it could be about, but yeah. But I'll rework this section a little bit. Because I do want to add in that review of rules. And then we'll review it later. We'll come back to this section another time. Go ahead, Carol.
Hi, Carol Jason. Somewhere in all the paperwork, I do remember reading where Washington State says that the doctor is responsible. If you have a license, you're responsible to handle pain management. And so I'm just curious. I understand this is the continuing education part of it, but if PAs, ARNPs, and anybody with a medical license is responsible to handle pain management, it's part of the license. Wouldn't it be important that you have that distinction between physical dependence and substance use disorder, and that as a the medical commission that that they know this? Like, I mean, how do you know that they know this? Because I've gone to doctors and they've said, "Oh, yeah, I don't do opioids." And that's like, "Oh, okay." So, isn't it important if you have it in one section where you're stating it is part of your job? If you want to be a doctor here, if you want to have a license here, pain management is part of that. So, and this is telling you to get the qualifying education. So am I coming clear with what I'm trying to say? Like, this would be a qualifying um, for them to have that education, like that everybody would be equal.
I mean, I may be wrong, but I don't think everyone who's an MD is required to prescribe opioids, or everyone who's a PA is required to prescribe opioids.
But in all of these in all of this, because there's so many pages to this, there is one line where it says that it is their responsibility to manage, to treat pain. Uh, I, and I can look at it when I'll turn my mic off and I'll try to find it. But, it says that that's part of the license, is as a doctor, you are treating pain. That is part of your job.
So I think
So-
you might have maybe misconstrued it. These rules only apply to physicians who prescribe
Right.
opioids, and not every physician prescribes opioids. So,
Oh, okay. Oh, I
so
did.
these
Okay,
rules
I did
only
not know
apply
that.
to those that do. So, like a radiologist who doesn't prescribe opioids, still a doctor, but he doesn't prescribe opioids, and so
Right.
he wouldn't be required to do any of this. So,
No, but a regular, like a primary care doctor, when you say like not the specialist like a radiologist or
mhm.
but do all primary care doctors?
No,
Oh, okay. I did
I
not know
think,
that.
I mean, my understanding is that's, a choice, whatever their, what a primary care doctor wants to do and not to do. I don't think
Okay.
they're required to.
Oh, I did not know that. Okay. Thank you.
And Katerina says, I think there's a distinction between treating pain and pain management, though. And I agree. That's why there's a separate section for pain management specialists and those that just treat pain. So, okay. So this will get a rework. If you're okay with it, I'm going to revise this section to just eliminate that January 1st, 2019 date because we don't care about that date anymore. And this is just a small change to take out this word of, I think. So yeah, this section will get a revisit. Does anybody have any other questions or comments about that section before we move on? Doesn't look like it. All right, so now we're going to move on to acute non-operative pain and perioperative pain. So we're in 880. I'm not sure if there's any changes there. There is not. Does anyone have any additions they want to make to 880? Which is about patient evaluation and patient record. Nope. Okay. Let me see if there's any changes here. Okay, there's one comment. All right, so 885 is about the treatment plan for acute non-operative pain. There's no changes, but there is a comment. So Dr. Stanos, who I don't think is here today, I don't see him. He has suggested that we remove these couple of sentences because he thinks it might be being read as a hard limit. So what are your thoughts, commissioners? I'll just read it aloud. It says a 3-day supply or less will often be sufficient. The physician shall not prescribe beyond a 7-day limit or supply without clinical documentation in the patient record to justify the need for such a quantity.
Well, I can tell you that in the emergency department or urgent care clinics, that is a 100% rule that is often quoted to patients.
Like in a good way quoted, or like in a we can't prescribe for your pain kind of way quoted?
Well, it depends how badly your pain feels and whether you're the patient or the family member. The truth is, the response I get from providers is that they're glad to have some sort of guidelines to be able to tell particularly repeat visitors for opioids that I can't give you any more than 7 days, I'm sorry. As opposed to those who require more than that say, well, all she would give me is 7 days. And in fact, we have had a few complaints on the commission by patients who said that they needed more pain medicine and they were left in the lurch because all they got was a week and they had no primary care physician, they had no follow-up standard, they had nowhere to go. So Where am I going to go? Out on the street? That's a direct quote.
I can definitely see from a patient perspective, if somebody didn't have a primary care relationship and had some kind of legitimate severe pain, if you give them 7 days, they're never going to get in the door to see a primary care physician on their health plan that's taking new patients, yada, 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 within 7 days. So I can see like there's a legitimate argument for pushing that back, but also I get that if people are actually drug seeking and repeat and coming back, that like they're just going to demand more medications. So how do we split the baby and say like for legitimate patients who have a new acute pain condition that is likely to last more than 7 days, that's going to require either a primary care visit or seeing a specialist, but it will take them longer than 7 days to get in the door, even if they try their hardest? Like, what's the right answer there, friends?
So real quick, Cindy, and then I'll call on you. So something that is in the rule, which I've had to remind prescribers of, is that if they document it, it's not a hard limit. They just have to document why. And maybe that's a barrier to care for the physician. Maybe the physician doesn't feel like they want to document it. I'm not sure. I know, speaking as Jeb, he would want us to do less documentation, right? Because that's what their folks want. But I mean, I agree. It's not a hard limit as long as they document the reason, which is true of most any kind of care, you know? Go ahead, Cindy, you have a comment.
Yeah, I agree with taking it out. My father-in-law was waiting for about 6 months for hip surgery, and his medication was prescribed at the 3 days at a time. So you have to drag yourself all into the pharmacy. You have to try to go on my chart or wherever else to try to get your refill. And yeah, like Dr. Lopez said, that is what people are told over and over and over again is 3 days or the 7 day.
I'm just the PA here.
But you talk like a doctor. Maybe that's why.
So Ed, are you concerned with removing it? I mean, it gives us suggestion, but it's being taken as mandatory or
No,
an excuse. Yeah.
Well, again, I think you're absolutely right. It's sort of it's dependent on the provider itself. You know, I think there are some physicians and PAs who feel a sense of relief that they have some sort of imposed limitation that they can tell somebody, you know what, can only give you a week's worth. Now, it depends how that's delivered as how it's taken, just like any communication, right? And some people deliver it in a way that is not appropriate, and then some people deliver it in a way that it is appropriate. And if a provider were to say, look, all I'm able to provide for you now is this week's worth. However, we can see what we can do to get you dialed in with a local community health clinic for follow-up so that you can go ahead and get what you need in the event that you need more until you get in to see your orthopedic surgeon. And I think, again, you can't put that all in rules. You know, that's part of the CME process. But I don't think that we should extract it. But what I think we should do is be able to educate our providers more that, and this does a great job, to be able to, in totality, educate our providers, whether they're in the ER, urgent care, primary care setting, or wherever, the surgeons, that pain management is their responsibility and they need to do it in a prudent way with compassion. And I think this document in total is trying to say that. And taking this little piece out, I don't think it's going to change anything.
It can be rephrased perhaps to be
Perhaps, yeah.
less. I mean, because it says this, you know, it looks like a hard limit, even though because someone reads 3 days or less, they'll ignore the word often. And then they will shall not prescribe, and they don't even get to the clinical documentation piece.
Yeah. Yeah, I can change this to say something more like, if clinically indicated, you may prescribe beyond a 7-day supply or
think
something like that.
if that
Yeah.
was there, I
Mhm.
think it would help trigger in their head, oh, well, maybe if it's clinically indicated, I can give more.
Mhm.
Yeah.
Do you
Well, and it
think
needs, oh, sorry, it needs to be a positive statement instead of shall not.
Exactly.
So I
Shall
think you're
not,
right.
shall
They
not is
stop.
negative.
Yeah.
Yeah.
do you think that the providers who are currently using this as a shield to hide behind to not prescribe will behave any differently if we add that sentence in to say like, unless clinically indicated? Do you think that will change their behaviors?
Yes and no. I think the person who comes to work with the intention of compassionate healing, it will help change. Those who come to work because they really hate what they're doing and they don't want to deal with pain management won't change a thing.
To be fair, those people, no matter what we put in or take out, it won't change a thing. So
Precisely right.
so let's aim for the ones that it will matter for and make
Correct.
it
That's
impactful
correct.
for them. Okay, got it.
Correct.
The statement quoted here is mostly I see commonly used by emergency room docs or urgent care physician, and I think partly because it's that usually emergency room and urgent care is like turnstile. It just basically revolving door, and they don't follow the patient. There's no continuity care, and that's precisely the concern. I think from those clinicians that they usually, even they feel compassionate, just that they're concerned about they're not following up on the patient when you statement 4 say the physician shall evaluate the patient if it does not follow pattern, but they're emergency room doctors, they don't follow the patient to do further evaluation when the patient says I need more medication. So basically it kind of becomes it's just the reality of the system. When they come into emergency room again, it could be seen by another provider who may or may not interpret it that this patient is actually drug seeking. And that's why I often say because the patient just kind of becomes a revolving door versus that if they do have a true continuity care, if they have a regular primary care physician they're known to that primary care physician, then it's better evaluated, for that. And that, it's not going to be, say be interpreted by the primary care physician as a hard, um, hard sell that to say it has to be less than 7 days.
So when I revise this, I'll take that into account. Thank you, Dr. Chang. Okay, so this one will revisit that little end of sub 3. So in reading 4, I kind of want to change it. I don't like it. So, how do we, because this sentence is saying, it's saying that they shall reconsider. I don't know how we would enforce that piece. Is it ever appropriate
It
to
may be
just,
impossible to enforce.
Do we need
well,
Maybe just one sentence saying, reevaluation is appropriate or something, whatever. I don't know. Shall is,
Can we
Is
strike
this
shall and say it is recommended that
mhm.
patients be reevaluated?
is this trying to catch the patients who are not healing up as fast as you think and or needing opioids longer than you think?
yeah,
Possibly, but
yeah.
so considering that this is in the acute, I think this is non-operative, right? Non-operative. Okay. So even though this is in acute non-operative, would you ever just straight up discontinue opioids? I don't know. Is that appropriate?
Not without a new assessment.
I mean, if they're coming back to an ER, they'll do a reassessment,
Mm-hmm.
but that's not necessarily discontinuing. It's just not renewing. You know, but they don't meet I don't know.
Amelia, we had
I'm
some hands
bothered
up.
by that paragraph, but
Yeah.
other than recommending a reevaluation if pain persists despite treatment.
Could we just end the sentence after the word recovery? Or do we need this reconsider the use? Tapering and discontinuing.
I would get rid of the tapering. Yeah. And I'm
I
not
love your
sure if
suggestion,
I like
Amelia.
shall.
Amelia?
Yeah, real quick. Sorry, Micah, did you have a comment or did your comment get taken care of?
Well, I mean, you all were discussing sort of the origins of this, and I was just going to raise the last time that this came through, which was, I believe, 2017, 2019 times. This really was targeted towards what ended up being the source of a lot of the overprescribing, which was urgent care, dental settings, and they were short-term prescriptions. And so that's really what this was coming at. And I can't quote what the science was at the time, but there was a reason that they settled on the often a 3-day supply should be sufficient. But obviously we're at a different time, and so a different consideration is certainly warranted to at least be looking at it. The reevaluation and not following the expected course that directly came from, I believe, us at the time, specifically Dr. Roberts, who was a surgeon, and so that really was about follow up from a surgery, and maybe they're not following the expected course. There's an additional acute injury that maybe is stacking on top of that, and so that really is where the thought process came from here.
So real quick, Micah, do you think it would be appropriate to remove, like just end the sentence after recovery and maybe change this shall to a should? Or do you think it's something we have to mandate, require?
I mean, I think it's a question for the clinicians who have actually been in this space at this point. The way I view this rulemaking is we've seen what was frankly mandated and to some degrees pushed on, and we have to reevaluate for the current clinical settings, both for the clinicians and the patients, and what we're seeing. At the time, as I said, there was a pretty large issue. It wasn't the chronic pain community that the issue wasn't the chronic patients. It was acute prescribing. It was the prepackaged dental stuff. It was surgeons giving 60-day supplies when not indicated. And so that's really where the excess supply was at the time. I think that we're looking at a different situation. So I would defer to the clinicians' judgments.
So do we need to specific call in this section, for that it's very specifically for surgical recovery? So basically if you say for post-op recovery, the treating physician, then that's become more specific.
Amelia, correct me if I'm wrong, but there's a different section for that. That's acute perioperative. This is just acute non-peri.
Non-operative, yeah. That's why I'm wondering if it's, I mean, if this is non-operative, is sub 4 appropriate here? If it's non-operative, I don't know.
Okay, that's what I wanted to bring up. So this is a non-operative section. Okay, so I suffered with the mesh for 15 years. So and I had pain all 15 years. I had 12 surgeries, infections every month, sepsis. But there were many times, because I had 12 surgeries, so 15 years, there were many times that I didn't have surgeries, but the pain never went away. So that's why for me, I would say there was never a day I wasn't in pain until I had it taken out. And so I did everything I was supposed to be doing, but I was never out of pain. So that's why, for me, there is sometimes times where you're in pain, you're following everything you're doing, and the surgery is over and done with, but you're still in pain.
So I'm wondering if that, in your situation, if it's considered you're a chronic pain patient, which
Yeah.
if so, then this would only apply if you had acute pain unrelated to your chronic pain
Okay.
in a non-operative setting. I know
Okay.
it's hard to keep
Yeah,
it
like you hurt your
straight.
ankle, you break your
Yeah.
ankle, right?
Yeah.
Or you have
You
a
sprained your
terrible
ankle. Yeah.
Okay.
back debilitating back thing when you picked up something, or in a car accident. I mean, those kind of acute problems. So
I mean, I don't want us to go down a rabbit hole in this one sentence. I just didn't care for it when I read it.
I don't like it. I mean, I could easily get rid of it, but or rephrase it.
So as a person who had a dislocated shoulder way back when, this would apply. If we're keeping the next section, number 4 here, that says the physician shall reevaluate the patient who does not follow the expected course of recovery, then it covers those people, right? If we strike the 3-day supply onwards, to leave that first sentence we're talking about, then yeah, the people who have acute pain that like that dislocated shoulder didn't recover as you expect, you're reevaluating the patient with bullet 4, right? And then follow-up visits must include, if we're keeping 5, which there's no changes suggested, I think it covers all those scenarios where somebody non-op acute pain got medication, isn't recovering as quickly. These rules say you got to reevaluate them. You got to have goals for follow-up visits. I feel like that covers it. So I would love to strike a 3-day supply on there if that's okay with everybody else.
I mean, clinicians, what are your thoughts about just taking this sentence out?
I mean, Ed just went through a whole reason why to keep it in, right?
Yeah, I still have heartburn with this.
Yeah.
Yeah, and that goes kind of follow to 4, and I still, I don't like that sentence at all, because again, if we're using a shoulder dislocation, you're seeing an emergency room, and didn't follow the expected course, and which physician are you say shall reevaluate the patient? Is it the emergency room physician needs to reevaluate the patient, or the referral that goes to the ortho to reevaluate the patient? Then it's the ortho's responsibility. So again, it's not 100% clear. I just don't like number 4. So
I don't know if it's okay. I had my hand up, but I don't see people are calling on the hands so much. So is it okay if I just chime
Yeah, go ahead,
in?
Rebecca.
Okay. So I'm a pain physician, and I was thinking that the 3-day supply is useful because if it's non-operative and you're not going to follow up with this patient, you probably won't want to prescribe more than 3 days. So it's just helpful to give a little guidance. And then I'm thinking for number 4, it's not necessarily that the ER doctor needs to follow up with the patient, but if the patient is requesting more opioids, is how I'm reading this, that then there should be some follow-up. And it's whoever is prescribing the next prescription.
That makes sense. Okay, so we're already rewriting this highlighted here. I can rewrite 4 based on our conversation. And then Rose, you still have your hand raised. I'm not sure if you had something else to add.
Nope, that was left over, but I do think we should probably get Dr. Stanos to weigh in since it was him who suggested removing it.
Yeah. And I can send it to him. And we also have a pain management specialist, MD, on the commission now. So Dr. Lee, I can also send it to her and have her review it and see what she thinks. Okay, so these two are going to get changed, and then we will revisit them later. We will revisit everything at the last workshop. We will go through the full, all the changes that we've made. Okay, so we do have some changes in 6. This is just like a rewrite of this. Okay. I like this rewrite. Because now it just says if prescription results in the patient receiving opioids in combination with other medications, such prescribing must be in accordance with 919970, which we've already reviewed. Does anybody have any issues with the change there? No? Okay. All right, and then Micah had a comment. So we have sub 7 that says long-acting or extended release opioids are not indicated for acute non-operative pain. And Micah says, does the data still support this? My recollection is that this was a Suboxone issue. Go ahead, Rose.
Yeah, I hate this. I have always hated this. For those people who are getting even low dose extended release opioids so they can sleep through the night if they have acute pain. Like, I'm not saying every person with acute pain, it's appropriate to have extended release opioids, but there are some that will. And to just take that off the board and not even have it as an option in the rules has always driven me nuts. The provider should be able to prescribe what's appropriate for each patient if that patient needs extended release opioids, rather than taking short acting ones like 4 or 5 times a day. I hate this, and I don't think the data supports it now, and I'd love to strike it, but that's me.
And Dr. Dale, did you have a comment?
Yeah, I was going to say with the buprenorphine, it's some people consider it long acting, some people consider it like more of a medi acting, and so I'm thinking that's what he meant by Suboxone, like questioning if that counted as a long acting or not. It is used for acute pain, and a lot of papers are now pushing for its use for acute pain. And so I think it would be okay to assume that buprenorphine would not be included in the long-acting category is what I was thinking, but I don't know if we want to like make that more explicit. I mean, there is a lot of data to show long-acting opioids can cause harm and are not indicated for acute pain, much too dangerous, and there is a lot of data on that. So I would vote for not scratching it, but then the question is, do we need to like make an exception for buprenorphine or not? Is it considered long-acting or not?
I mean, I think a lot of clinicians may consider it long-acting.
Then maybe it would be worthwhile to consider saying long-acting opioids are not indicated for acute non-operative pain with the potential exception of buprenorphine. I don't know if that.
Yeah, good luck to me. Can you spell it for me, please?
Sorry, B-U-P-R-E-N, Bupre. Sorry, you were right. O-R-P-H.
H-I-N-E.
Yeah.
Oh, well, okay. I hardly ever spell that word, so thank you. I mean, commissioners, how do you feel about that addition?
Well, in my mind is that there's actually a difference between long acting and extended release opioid. So the long acting would be strictly, say, by their natural property, like buprenorphine, that's once a day or twice a day, just already by design is that way. Versus the extended release opioids is actually it's still same opioid, but they make in such a way that it becomes slowly released. For instance, like MS content versus short-acting morphine is still the basic ingredients morphine. It's just that they make it in such a way not because they change the morphine property, but they becomes they coated such that they are slowly dissolving and it becomes slowly released. So I'm, you know, I'm basically just thinking that we should strike out the long acting, but still keep the extended release opioid not indicated for acute non-operative pain.
Go ahead, Rose.
I'm just gonna say again, all the studies that were done about extended release opioids consider them dangerous for people who are going to misuse them because they crushed and consumed them in ways they were not intended to be consumed. And if they're going to do that, they're going to misuse any opioid. Short acting, long acting does not matter. For the people who take them as prescribed, who in theory, anyone who would get them prescribed will be well screened for any history of addiction or misuse or overdose history. They are safe and effective and they're prescribed every day for people with pain. So, yep.
But
And the other
these
thing
are
is,
acute pain patients, so I don't think the acute pain are necessarily that we're dealing with people with chronic pain to begin with in this section. Is that right? I was going to ask about that. But
So
I mean, if
that,
you have an acute pain problem, someone probably wouldn't really want to start them on an extended release opioid.
not necessarily, but I just hate that it's being taken off the table entirely because for some people it might be the right choice. And who are we to say? Like, no one can get them in the state of Washington for acute pain for any reason because some people might have misused them in the past. And frankly, no one's studying their safety now. No one. So we don't have current data on are these medications being misused or are people developing substance use disorder after taking these medications as prescribed? I hate that we're removing safe and effective medications off the board when people take them every day and they're fine. So
go ahead, Dr. Dale.
Oh, I was going to say another long-acting medication is methadone. So that's another, which is a pretty risky opioid. So that's why I think maybe leaving the long-acting and then also the extended release, because the long-acting would be like roping in methadone too. Would just be something to think about. And I could give data. I could send you data on the use. Detrimental use of long-acting. Is not a safe medication for acute pain, if people are interested.
I mean, that's if you have data, then yeah, we can. I mean, at least add that to the rule file, and include it in future workshops so that we have it. That would be fantastic if you could send that along.
Well,
Okay,
you know,
sure.
the things I have here is that this is strictly talking about acute non-operative pain, not chronic pain. And we're not talking about people who's going to become the opioid, abusing opioid medication with this. It's more concern is that it's an opioid naive patient and you starting right up back using the extended release opioid, then that's a concern. And usually, as for primary care physician, we start with shortest acting, short acting opioid for an opioid naive patient to give them a try because you don't want it to develop, side effects and so forth, but you want to control the pain, but you don't start it right out back just using the extended release opioid.
Okay, so after that, you want to keep it saying long-acting or extended release opioids are not indicated for acute non-operative pain. Do you want to add in, excuse me, with the exception of buprenorphine?
Yeah, if you want to make exception, I'm okay with that. And also Dr. Dale's suggestions of adding methadone. Although methadone is technically, I don't know, methadone is kind of, have a kind of
No,
unpredictable
I didn't mean as
half-life.
an exception. I
Oh,
just meant
okay.
that that's what was in, like the long
Oh, I
acting,
see.
because there was some question about naturally long acting versus like something that was like synthetically made with an extended release, capsule.
I understood. Yeah. Yeah. I certainly methadones, it's kind of tricky, instead of unpredictable half-life.
Well, I'd like to speak in favor of keeping 7. And I think it's probably appropriate to add buprenorphine. I don't particularly, my use of buprenorphine is usually with opioid use disorder primarily. In fact, it turns out just this morning I was speaking with someone, a nurse who was struggling with one of our patients in one of the environments that I work in that has chronic pain. And we has been on an opioid for quite some time. And we are considering the use of buprenorphine for chronic pain. But nevertheless, I think now that we have buprenorphine, it is used in very, very common in most settings, and I think it's used very safely. It's well proven. So I think adding buprenorphine would be, I think, a good idea. So I speak in favor of 7.
Okay. Any other comments about 7? Okay. And again, though, this is not the last time we're going to look at this section. So, for the last workshop, whichever ends up being the last one, we will go through all of these sections again and make sure that everybody agrees with the language. So, okay. We're not messing with 8. And we've got no suggested edits to 9. So we will move along. So this is the treatment plan for perioperative pain. I don't know that there are any changes. Oh, we did change 3 to 7. In this sentence. Go ahead, Dr. Dale.
Oh, I was wondering why it was changed from 3 to 7. Was there data to support that, or?
Micah, this is your suggested edit. Do you have any comments? Go ahead.
Yeah, so just generally, there was an ask to provide more flexibility, not only from the patient population, but also the clinician population. So you will see several extensions throughout the rule set. Probably the most significant one is the subacute section. So when I was calculating out the timelines of acute, subacute, chronic, subacute calls for I think a refill at 14 days, but the total timeline between subacute onset and chronic is like 32 days. And so, that one, I simply just suggested that they get a single prescription for that phase as opposed to having to refill in the middle of it. So this is an extension of that, is instead of the 3, just go to the 7.
I just have a little bit of concern based on data with the BRE Collaborative and the Michigan Open that there's a lot of leftover prescriptions. Most patients actually don't take their opioids, and so this will impact the amount of opioids that are kind of floating around in the community. And I would suggest looking at the data, if it's non-operative, a 3-day supply should be more than ample. For moderate to severe operative pain, we would recommend a 7-day prescription. So
This is
for
periop. Yeah.
This is perioperative pain.
this is
It
perioperative.
is operative.
Yeah.
Got it. Okay. Thank
And I
you.
also want to point out that it also says or less. So this is optional, not mandatory. 7-day supply or less.
Okay, yeah, no, that makes sense. I was thinking we're still in the non-operative section.
Yeah, we've moved to, I should have said perioperative pain, but so we're okay with changing that 3 to 7 then, yes? Thumbs up. Okay. Okay. And this again is just a rewrite of this 6 that talks about instead of saying sedative medication, we're just saying other medications. And that we're just changing this to say the same thing that the previous section said. And then we are back to 7, which is similar to the last one. So do we want to make 7 here look like 7 in the last one? Or is that appropriate for perioperative pain, acute perioperative pain? Go ahead, Dr. Dale.
I would advocate for it looking similar to the other 7. It is appropriate for acute perioperative pain.
Okay, I'm going to scroll, so look away if it makes you nauseous. Okay. Commissioners, are you okay with this change in the perioperative pain area? Okay.
Yes.
Keep that. Or just, that's just a grammar change. Okay, so we're done with that one. Now we're moving on to subacute pain. Let's see if there's any changes in 895. Does not look like it. Okay, so there were no suggested changes in 895. So 895 is the evaluation and patient record. And we've gotten no suggested changes as part of the petition or any comments on this section so far. So we will skip it for now. Sorry for the scrolling. All right, let's see if treatment plan subacute pain has any suggested changes. It does. Okay. This Micah talked about briefly. So this section is the treatment plan for subacute pain, and there's a suggestion to change 14-day supply to 30-day supply. Commissioners, do you have any issues with making that change? Go ahead, Dr. Dale.
Again, I have similar concerns about this in the subacute phase. This is a delicate time for patients and their recovery, and oftentimes people end up with a lot of leftover prescriptions and don't need a 30-day supply. So I would keep it at I would advocate for keeping it at 14.
I'm just going to point out, it says not beyond a 30-day supply. So again, they can do less than 30. And second, I understand maybe more than most, about the concern about people having opioids laying around, but prescribing is down 63% in this state. And right now, more people die of overdose involved with alcohol than do with prescribed opioids. So ensuring people get adequate pain control should be a high priority and carefully monitored, but people should be able to get the appropriate pain medication that they need, especially post-op.
So it looks like Dr. Stanos just arrived. I don't know if he's prepared to speak, but
Oh, no, I'm sorry. I apologize. My schedule got off, so I was in clinic, so I apologize. I just logged in.
no worries. So we're discussing this change to the subacute pain treatment plan, from changing to beyond a 14-day supply to a 30-day supply. And we have Dr. Dale who's here, who's wanting us to keep it 14-day. And it looks like this suggested change is based on a comment that you made, Dr. Stanos.
Yeah, I'm sorry. I don't know where I made a comment about 42 days. I'm sorry. I don't know. Has there been any other feedback, how other physicians have interpreted subacute? I mean, it's such a short period, and I don't know if it's ends up being like one visit in a primary care clinic, but I had I meant to ask, has there been any pushback from primary care that they, are they staying consistent with understanding what the subacute phase is? I don't know if there's any other physicians or from primary care what they would say.
Well, Dr. Dale, like I said, she was advocating for it staying 14 days. Sorry, Dr. Dale, could you go ahead and, since Dr. Stanos arrived in the middle of what you were saying, could you go ahead and repeat your comment?
Yeah, so I was saying that studies show that most patients don't take all of their opioids, so a 14-day supply is an appropriate time frame for a prescription and should be reevaluated if the patient's not meeting functional goals or continues to have pain, and not just prescribe 30 days because that's going to increase the amount of opioids in our community that are not being used, and I don't think it's great medicine, but.
And I'm sorry, again, I apologize for being late. Is this for the post-operative pain control or subacute follow-up?
Subacute. So it's the treatment plan for subacute pain section.
And is this, they're in the clinic, they are now subacute, so it's at least 6 weeks? Right?
Mm-hmm.
So like to me, it's just at that point, if you think they need, I understand the idea about giving them less amount of pain medicine, so there's a lot less unused meds. But if the person's going to continue after 6 weeks, if we, why, if they are having issues and you feel like they need 30 days supply, your hands are kind of tied at 14, then you have to do a second script. I'm kind of confused. I can see it for post-op, then they're only taking a small amount of pills, and we've seen the numbers go way down with the amount of, short-term prescribing. But if they reach that subacute phase at 6 weeks, maybe they are going to be tapered and they don't need a full 14 days or 30 days, but there's other patients who are on the other side that you're continuing to work with them. We have patients like knee replacements or things like that where they may have elevated pain for 1 to 2 months. So to me, it seems like that the physician should be able to make that call if they need a 30-day supply or 15-day supply if you're tapering.
But this is longer out than 1 to 2 months, right? This is moving more into the subacute chronic phase. And I'm just not sure, what is the data? My understanding is that the data patients aren't needing this, and then there's going to be a lot of extra. But maybe there's new data
I thought that
that
was
I'm
more
unaware
for
of.
the
or-
acute prescribing that, the patients don't need a 30-day supply. We give them 3 days or whatever, and they're finished. Most people don't end up needing chronic opioids. But my thought would be if it's at 6 weeks after their surgery and they're still needing pain medicine, to give them 14-day supply because that's the limit. Then you have to do multiple scripts if you wanted them to continue. So, that's what I thought the whole subacute phase was set up for, to make a good assessment of the patient. Do they need to be tapered off or not? If they need to be tapered, you're, obviously maybe stopping the medicine or giving them a 14-day supply. But on the other side, if that is the transition, if I can't see the practical part about it, because then you're going to have to give them multiple scripts if you're only given a 14-day supply. The other issue would be some insurance companies will only do a 30-day supply. And they'll say if you gave a 14-day that they're going to wait 30 days. So we've kind of dealt with that. So I'm not sure if anyone else has an experience with the limits on some of these days.
I'd also like to add, from a patient perspective, if that's going to require a new office visit, a new copay, navigating insurance, getting on schedules, it's incredibly difficult to get back into a doctor when you still have the same issue they're already treating. And if it's not that, and it's trying to get somebody on the phone in that doctor's office to say, hey, that pain medication that you prescribed me didn't go far enough, please do another refill. And now you're navigating, yes, insurance approvals, will the pharmacy fill it, do they have it? Rather than just, I think you're going to need this, please take as prescribed. Let's not make it more difficult and clog the system more than it already is, because it's burdened enough. And having people that are in severe enough pain to need opioid treatment, having to navigate all that again, when their doctor is already on top of what they need. This doesn't say they will prescribe 30, it says they can. So leave it into the doctor's care to determine whether it's as much as 30 days or somewhere less than that, but give them that discretion.
Amelia, is this under perioperative pain?
No,
or
it's
are we
under
talking-
subacute.
I know
Pain.
it's subacute, but that this also includes, say, an ER visit for backache, right? Some sort of thing, or shoulder problem or whatever. So it could be with a subacute, a perioperative, as well as non-operative acute pain. Is that correct?
Right. So
Yeah.
they're recognizing the progression of a patient from the acute non-operative or acute perioperative phase to the subacute phase.
Great.
So
Thank
this
you
is
for
what this is all
pointing
about.
that out.
Yeah.
It's quite small.
Yeah.
So Dr. Stanos, does that differ in your mind between, you use the example of a total knee replacement, which with rehab and everything, it could be, they're supposed to be quite painful. But for non-operative pain, there are also some other acute conditions that could be it. I just don't know if you want to, is it appropriate to lump these together? I hear Dr. Dale talking about less time, but we were expanding it to be able to cover some of the ones that are last longer, the pain lasts longer.
And I'm sorry, Dr. Domino's, the subacute goes to 3 months, right?
Yeah, that's what I thought.
Yeah, I just can't see someone that's say they do have a bad outcome and you're doing prolonged opioid prescribing, to just be doing 14-day prescriptions, during that period, in knowing that it's, it's almost like you want to justify it in your note. If you're going to prescribe, you want to justify the duration of the prescription.
I would just say it is a very delicate time in a patient's, if they are perioperative, like had an operation in their recovery, and this is where patients become dependent on medications. And so I think that having closer follow-up, monitoring their functional goals with a 14-day interval is not a bad idea. I think it would lead to better patient care. But yeah, that's just me.
I'm not saying that I don't believe in better patient care. I just think if someone's having a need and for us to have them go to the pharmacy every 2 weeks, and we're doing it because we think that's safer versus prescribe the amount that you think, whether is it 15 to 30 days during this subacute phase. Again, I don't know about giving people multiple 14-day scripts. If that's really practical. I mean, I think on the acute side, giving the limits on how much is prescribed, all we see is most of the surgeons give 42 pills for everybody, regardless. So maybe that's okay. I think that's a lot better than what was being done in the past. But subacute, that's why we have this, is you want to assess the patient, decide what they need. But if we put 14 days, then every script the pharmacy, the plans are going to say we're only going to approve 14. And it's just, I don't know. I think the physician should be able to justify it in their note why they are doing what they're doing.
This is Heather. So that is what the second sentence says. So up to 14 days, unless you justify it in the record, and then you can do a larger prescription.
So similar to what we are going to do in a previous section, we could make this a more positive statement because it shall not, So I think you're right when you mentioned before that they get to the shall not, and then they're like, oh, I can't do more than 14 days, no matter what. So I think we can reword this to be a more positive statement and, load up in the beginning that as long as they document it, they can prescribe beyond 14 days.
I'm for that. As long as the justification's before it. I think what happens is they just read the first part and they stop reading. So everything's like 14 days. And that was the whole
Exactly.
thing with the CDC in 2016. It clearly said in there without clinical justification. And unfortunately, most of the Part B benefit plans ignored that. And so if, like you said, if it's a little more positive, then I think that's good. And then Becca said, if you think they need just 14 days, you're within that range. But I do think a lot of these things get ignored, so it makes these kind of guidelines, or not guidelines, I'm sorry, rules a little tedious.
So yeah, we'll revise this similar to what we're going to do in a couple of sections ago. And again, we'll revisit this section later. Maybe at the next workshop, we'll come back to these two since they'll be a little more fresh in our mind. Commissioners, do you have any other thoughts about sub 2?
No, I think I'm okay with this.
I tend to agree with basically with everyone's position. I want to make sure that, again, we stress to all clinicians, prescribers, that just because it says 14 days is not a hard stop, and that they need to understand the concept of clinical justification for further prescribing if it's so warranted. And I think that puts safety within the secret sauce of writing rules, that if it's clinically justifiable, you just put it in the note with an examination and your recommendation, and you move on to 30 days or 40 days, whatever the case may be. But I think safety is essential, especially with what's happened in our country with opioid use, and I think that's part of the problem.
Okay, thank you. So we'll revise this to be more positive. And then sub 3 is just rewording like we've seen in the previous sections. Instead of saying sedative medication, just as other medications, and references the WAC that has that information. That is the end of that section. Are there any other questions about this particular one before we move on? Okay. All right, so we are at chronic pain. The very first section is patient evaluation and patient record. So as I mentioned previously, we do have some suggested language from the petition in this case. And so what I tried to do here was keep them side by side. That way you can sort of see the suggested language and then what we're proposing to make it in line with the suggested language. It's very similar.
Hey, Amelia, can you blow up the font a little bit?
Yeah. And you can also do it if you hover over the screen, you can make it bigger too.
I tried that and it's not doing it. Thank
Gotcha.
you.
I realize ours is a little wordier, but
I can only help Jeb so much, friends.
and ours is only different in that we added this statement at the end.
I thought that was fine.
Am I wrong? Or are we talking about getting rid of MMEs altogether in this?
It seems like we have discussed that, so I may need to come back to this one if we do get away from that.
Yeah, just trying to make it match. If we're keeping them, fine. If we're not keeping them, then that's not needed. Yeah.
So I'll make a note.
Or is it, it can't be solely determined by individual factor, including, like an MME, Does that kind of highlight that this is more complex? I don't know.
Well, and if we're removing MME, then this may be irrelevant. So
yeah. But I'm saying if you keep it in there, just so it's like there's other factors, right? So
yeah,
we don't want them to be doing things based on just one factor. I don't know. So
yeah, we'll definitely revisit this section, especially since it was part of the petition, because that's the whole reason we're doing this rulemaking. So we will have to address it.
Before you got here, Dr. Stanos, there's a sentence somewhere and we discussed above that says we're talking about patient functionality and quality of life. That's the primary thing we care about here, not dose or so like, yeah, the one thing we care about is the overall health, safety, and functionality of the patient and their quality of life, not any other one thing.
Okay. So again, we'll revisit this section.
Dr. Dale had a comment.
Oh, go ahead, Doctor. Go ahead,
I guess
Dr.
I'm
Dale.
a little bit confused. So this is the left one is a petition or something, and then we're making changes to our document based on the petition.
Right.
Okay.
So we
and right
received
now, what does the language say as far as ordering, prescribing, and dispensing, administrating, or paying
it doesn't
for
say anything.
Okay.
Right.
Okay. Are there limitations based on MME in right now? Like, is this necessary or?
And that's the other option. You don't have to change the language at all based on the suggested language from the petition.
Because the paying for part is tricky because I mean that's up to the insurance like that's not really something there's control over as far as I know.
And that's why we excluded the paying for part in our proposed revision. Yeah. Yeah, because we have no control. We have no say over insurance and things like that. So we can't get involved in that. So and again, we'll revisit this section, and commissioners, you may decide you don't want to add this at all, and that's fine too.
Why don't we just leave it there? And as
Mhm.
we revisit things, we can look at it again.
Yep. Okay. So skipping that part and then moving on to the next piece of this section. Right now it says the physician shall include in the patient's record, and it has a list. An appropriate, and the red line from Ms. Higginbotham wants us to add evaluation and history. Right now, it just says an appropriate history, including all of these items.
Isn't all of those items the evaluation, actually?
I mean, that's for the clinicians to say, I would say.
I'm not sure what is meant by the evaluation exactly. Usually like a history and physical. Did they mean like a physical, or
Is there
I'm
a
not
physical
sure.
later down in this section, Amelia? I mean, it's
Ignore the
this is the
red right now.
history.
Yeah, it's, and then an
There's the
appropriate physical
physical.
exam is down here. Yeah. So yeah, there's a physical
Well,
down
an
there.
evaluation requires a physical. So maybe
Right.
So I don't think we need to add this then, right? Evaluation
We do
here.
not need to add that. It's redundant.
Okay. Okay. And then from that same red line, instead of having, excuse me, so an appropriate history including C, which is current and relevant past treatments for pain, including opioids and other medications and their efficacy. What they're suggesting is saying instead prior non-opioid and non-pharmacologic treatments, including identification of those that were ineffective or harmful.
This is Rose. If I can speak to this, I think, and if Maria, you're still here, feel free to chime in. The deal is that most chronic pain patients are required to exhaust all other therapies and fail them prior to starting long-term opioid therapy. So this request is here's all the things I have tried and failed already. Please don't ask me to do them all over again, for the love of all that is holy. Because that's a long road of things that don't work while the person is continuing to suffer in untreated pain. It may be redundant because it's part of the, current and relevant past treatments, but I get the incentive for including the things I tried and failed already, please. I think that's where that is, but I'll let the clinicians decide if it's redundant or not.
I think they're kind of saying the same thing, both the current C and the suggested, they're kind of saying the same thing. It's just saying it in like a different way.
It's sort of implied, and their efficacy or not, right?
Right, right.
Yeah.
I
So
mean, you could
Commissioner-
just change it to say including opioids and non-opioids as instead of other medications.
Can we just say all current and relevant past treatments for pain inclusive?
You say like what, like including pharmacologic and non-pharmacologic therapies? Is that what Becca said? Something like that.
Yeah, and their efficacy.
I mean, it's if Dr. Dale and the other physicians can comment. Now, that's kind of what's understood to be done, right? So I just say the simplest, the simpler, the better.
Agreed.
So are you wanting to add, let's see, other medications, opioids? Are you wanting to just add these two, non-opioids and non-pharmacologic, or just leave it the way it is right now?
I think we're saying current and relevant past treatments for pain, pharmacological and non-pharmacological, and their efficacy.
I see. So take out this and replace it with this.
Pharmacologic and non-pharmacologic interventions and their efficacy.
Okay, I see. Okay. So like this, yeah.
And then strike everything
Yeah.
after efficacy.
I don't,
And then not have this at all,
Yeah.
right?
mhm.
Okay. So we're good with C now, commissioners. Are you okay with that? Dr. Domino says yes. Yes.
Yes.
Okay. All right. And so then D, right now it reads review of comorbidities with particular attention to psychiatric and substance use. And then the red line is suggesting to change it to past or current opioid therapy, including any successful prior use that may inform ongoing care decisions.
That's redundant. That was
I think
in,
so, yeah.
we just
I mean, I
added
think
to the earlier, it's the earlier
Mhm.
one.
Okay,
that's what
so
that's what an assessment's going to do. You know, this is almost like explaining everything that's just assumed to be done at the lowest standard of care. If they've had medications in the past, whether it's opioids or not, that have helped them, or you know, I don't know if we need all this extra. The red line that's in there.
okay, so no to
'Cause
this
it-
first one, right? For D, commissioners? Yeah, okay, no to that one.
Yeah.
All right.
Get rid of that.
And then they want us to add an E and an F. So there, I mean, D already says this about attention to psychiatric. And then they want us to say substance use and psychiatric history, which shall be considered as part of a comprehensive assessment, but must not be used in isolation to deny medically appropriate care.
I mean, it's part of the comprehensive
Yeah,
assessment.
that's what I think
it's
too.
just
Yep.
redundant. I just
Mhm.
get rid of it.
Okay.
And comorbidities, we have listed.
Mm-hmm. Okay, so no to E and F, right?
Yeah.
Right.
Yeah. Okay. Get those out of here. Yeah, they wanted us to say an appropriate physical examination. But I don't. Okay, so
Don't we have physical down below somewhere?
this is the physical
we're in-
exam. Yeah, this is a new
Oh, I
subsection.
see. Yeah.
So they just wanted us to add the word and before appropriate physical
Amelia,
examination. Yeah, go ahead, Carol.
with the removal of E and F and just leaving D, review of what, so just the review, what does that mean? Like, what's the, you review it? What,
So they
What-
talk to the patient about their comorbidities.
that's it? That's what that's there for, just to talk to the patient about it? Right?
It probably also means a chart review.
Mm-hmm.
You.
It just it's, you know, asking if they have any history of addiction or misuse themselves or in their family or all the other risk factors
Oh,
that
okay.
doctors dig
So
into
it's
before they prescribe anything, right?
Okay.
not to add more, but it's like review and consideration of,
Yeah, yeah.
right? You review it, but you're considering it. But I know that's implied, but maybe I'm I'm trying to keep less is better, but
I don't care if you want to add the word consideration of. I mean, it means more deliberation, not that anyone's gonna be
yeah.
focusing on it, that,
Mm-mm.
No,
I mean,
you know,
it's not necessary.
review
I
is,
just was
we
like,
all,
okay,
Yep.
yeah, it's not necessary.
okay, so, and then they want us to change.
I'm sorry. Can you go back up a little bit? I'm just,
Sure.
and I'm sorry I have to jump off the call, but we keep saying review of comorbidities with particular attention to psychiatric and substance use. Um, is psychiatric. I mean, people have like psychosocial things that aren't purely psychiatric.
isn't it behavioral health?
Yeah, it's more like
Yeah.
behavioral, and almost psychiatric is taking it too far to a diagnosis. You're looking at behavioral comorbidities or psychosocial behavioral, I don't know, something like that. Seems like psychiatric is too medicalized because
So,
you know,
Psychosocial
like attention to
behavioral health,
psychosocial, I don't know.
yeah.
It's review of comorbidities with attention to.
should we have history here instead of like just leaving it as one word? I don't know.
It's beyond psychiatric. I mean, because
Yeah.
it's your whole social environment, your other behaviors. I mean, where you live, what kind of family you have, if you're on the street. I mean, it's just very complicated. So psychiatric just seems like you're given a little diagnosis,
Yeah.
and that doesn't encompass your whole social environment and your overall mental health.
Well, we can certainly expand on this idea.
Would psychosocial risk factors say
And
what we're trying
substance
to
use.
say?
Mm.
And substance use?
I mean, normally you would get a substance use history as part of your social history, which is you're required as a consultative, visit. But
is that like, obviously for the rules, are we trying to say what's the lowest that you need to make sure you do that, right? Like I know what you're saying, but it's like we want to make sure that they're looking at these comorbidities. Like, yeah, it's how do you group it the right way, right?
I think psychosocial.
Because the other part, it's,
risk
I mean, I
factors
keep
is
thinking
good.
like a person with pulmonary or lung disease, that's a huge medical comorbidity, and they probably see more of those issues, medical risk factors, separate from just psychosocial and substance abuse. It's like, medical, psychosocial, and factors. And I don't know, it's almost like you need 3 or 4 things to encompass this because it's, yeah.
Okay, well, I can review this one and change
if you
it.
can send on, just think about it a little bit because it's a lot there and there's not much said there. There are a lot of risk factors.
And if it's always used consistently throughout, right? But have that same kind of theme. And then it's
because it's now 2:50.
So we'll
and
stop
we're going to
here.
be pausing our discussion shortly. So
yeah, we can start in sub 3 next time.
Okay. Well, great. We'll continue our discussion of the draft language at our next workshop. Thanks everyone for your participation. Ms. Boyd, please discuss our next steps.
Okay. And I apologize. This is going to start at the beginning. I will go to the end as soon as it loads. Okay, so the next steps for this rulemaking effort are additional workshops. And then within the next 2 weeks, the revised draft language should be available on this rules page, which you can navigate to by clicking the link on this slide. And then a notice will be sent out via our Gov Delivery distribution lists when the updated draft is available, and then also again when the materials for these next workshops are available. And then if you have any questions, you can email them to medical.rules@wmc.wa.gov. And then that is all I have. I appreciate everyone's participation today. It was a really good workshop.
Yeah, thanks, anyone. We just want to know, are there any questions that haven't been addressed as far as what we discussed today or the future workshops? I have a question, Amelia. What happens if we aren't ready at the end of the September workshop?
Then we will just schedule more, and we'll make that decision probably at the July or August workshop. We'll decide if we need to have more workshops. So we'll just schedule more after that.
Okay. Anyone have any questions? If not, thanks everyone for attending. Appreciate all your comments and suggestions, and see you next time. Bye.
Thank you.
Thank you.
Thank you.
Bye.